Good afternoon, ladies and gentlemen. Welcome to the webinar organized by the European Reference Kidney Network in association with European Society of Pediatric Nephrology. It's my great pleasure to introduce you today our speaker, Professor Gema Ariceta, who is head of the Department of Pediatric Kidney Disease at the University Hospital Vall, and she is a full professor of pediatrics at the Autonomous University of Barcelona School of Medicine. Gema will talk today about Claudin-related disorders, and I will moderate this webinar today instead of Francesco Emar, who is on honeymoon and cannot do the job. So Gema obtained her medical degree from the Basque Country University in Spain, and then he specialized in pediatrics and pediatric nephrology at the University Cruces Hospital in Spain, and finally he achieved her doctoral degree from the Basque University. Gema spent time in the Division of Kidney Disease at the Children's Memorial Hospital of the Feinberg School of Medicine and Northwestern University of Chicago in the US, and she also graduated as a Master in Science and Clinical Investigation from the Graduate School at Feinberg School of Medicine in Chicago. Gema interests of research are very wide. We all know her from very different publications. She published altogether about 160 papers in different high-impact journals, and her research focuses on primarily tubulopathies, inherited rare kidney disorders, and also, of course, on familial hypomagnesemia with hypocalciuria and nephrocalcinosis. Gema is a co-founder member of the European Rare Kidney Disease Network, ERKNet. She is a board member of the Tubulopathies Working Group of ERKNet. She is also very active at the ESPN, and we are very happy to hear her talk today. Gema, I will stop my introduction now. I will give the word to you, and we are very much eager to hear your talk, so you're very much welcome.
Thank you so much, Elena, for this very nice introduction. Welcome and good afternoon to everybody. Welcome to this webinar entitled Claudin-related disorders. Before starting, I have no disclosures to declare. Okay, so sorry, I'm trying to escape my image. Okay, good. So we know that at the tubular renal tubular network there is transepithelial and also paracellular transport. Until recently, we hadn't very much knowledge about paracellular transport. But tubular paracellular transport is also tightly regulated and can be highly specific to its nephron segment. The permeability characteristics of the paracellular junction to various solutes are determined by claudins. Claudins are key integral proteins expressed at the time junctions of epithelial and also endothelial cells. And these claudins interact between themselves and also with other claudin family members within the same plasma membrane or with the adjacent epithelial cell membranes, and create pores of barriers to ions and other small molecules. You can see here at the cartoon the structure of one claudin. In this case is claudin 19, and the structure consists of 4 transmembrane domains and 2 extracellular loops. And you can see also that you can see the structure and the interaction between claudins are responsible for these very selective structures to control permeability. Okay, let me if I can move on. Okay, this one. So here you can see that in the mammalian kidney, every tubular segment expresses a specific set of claudins that give to that particular segment unique properties regarding permeability and selectivity to the paracellular pathway. Today we will talk about Claudine 10 and to Claudine 16 and 19 because those are the Claudines that are related to human diseases, to human kidney diseases. At this table, you can see the physiologic role of claudins in the mammalian renal tubule. You can see the tubule localization of different claudins, their permeability properties, and also their physiological role. And in red, there are highlights those claudins which are associated with human kidney diseases. At the thick ascending loop, there is a transepithelial transport and also a paracellular transport. The transepithelial sodium chloride transport is based on the activity of sodium potassium chloride channel and also the potassium channel at the luminal part, and also the transport, the destruction of sodium and chloride at the basolateral side by the sodium potassium ATPase and also through the chloride channels. As a result, there is a transepithelial positive positive voltage with a positive voltage at the luminal area, and that is the driving force that paracellularly through claudins, mostly 16 and 19, the divalent cations, that means calcium and magnesium are reabsorbed and go to the blood. Excuse me. At the medullary tall, the only claudin that is expressed is Claudine 10B, and this is responsible for half of the sodium reabsorption at this level. Overall, at the tall, 1/3 of the sodium chloride is reabsorbed. Of the 1/3 of the filtered sodium chloride is reabsorbed. Today, we are going to talk about claudins and kidney disease. So far, there are 3 claudins, 10B, 16, and 19, that have been recognized as a cause of rare autosomal recessive human syndromes. Further, Claudine 14 variations have been also associated with hypercalciuria and kidney stones. Let's talk about Claudine 10B and Elix syndrome. So the human Claudine 10 gene is located on chromosome 13, and there are two variants of Claudine 10, and the one and the gene that is associated with tubular disease is Claudine 10B. The specific effect of Claudine 10B is to increase the paracellular permeability to sodium. Elix syndrome is a recently and rare autosomal recessive salt-losing tubulopathy. It was described in 2017 and is caused by Claudine 10B loss of function mutations that lead to lower paracellular sodium permeability in the tall, sweat glands, and also salivary glands. So what is the phenotype of this salt-losing tubulopathy? There are several small cohorts of patients described, but in general, patients present with a picture of hypohidrosis in almost every patient, hypohidrosis, hypolacrimia, and xerostomia. Also, electrolyte imbalance is very frequent, and ichthyosis as well. Regarding electrolyte disturbances, hypokalemia is common, but hypomagnesemia has been described more often. And 25% of patients were observed to have CKD at the time of diagnosis, and nephrolithiasis can also be observed. In some patients, hyperaldosteronism, but without hyporeninase, was observed. ELIX, the ELIX is the acronym from the major characteristics of this rare tubulopathy: hypohidrosis, electrolyte imbalance, hypolacrimia, ichthyosis, and xerostomy. What is the pathogenesis of this tubulopathy? As I told you, at the medular tile, Claudin Chambi is responsible for regulates permeability of the sodium to the sodium, and when there is a mutation, there is a decrease about in sodium reabsorption, and as a result, patients have a salt-losing tubulopathy. On top of that, there is an imbalance between the transepithelial voltage, and that impairs the sodium. That impairs the calcium and magnesium reabsorption as well. And the main factor is the decrease when at the ELIX syndrome, the loss of function mutation of the Claudin Chambi gene impacts and decreases the sodium permeability, and that leads to an extracellular fluid depletion related to sodium renal loss. As a consequence, patients present secondary hyperaldosteronism, and that leads to potassium renal loss and hypokalemia, and also increased magnesium and calcium reabsorption, leading to hypermagnesemia that, as I said, is common in many patients. So now we have a question for you. What about this syndrome? What of the following manifestations is not characteristic of ELIX syndrome? Option 1, hypohidrosis. Option 2, hypolacrimia. Option 3, hyperkalemia. Option 4, hypermagnesemia. And 5, all of above. I don't know if you
see the poll, Gema, now, so you will see the answers. So
okay.
So can you see the answers, Gema, or should I read it for you?
No, can you hear and read them for me, please, because I cannot see them. Sorry about this, because it's quite confusing for me.
Yeah, right. So I think 61% of attendees have chosen hyperkalemia, 15 hypermagnesemia, and 22% all of the above. So maybe you can comment.
Yes. So I think most of them you were right. As I told you, this is a new salt-losing thrombopathy. So what happens is that sodium is lost by urine, and there is an increased sodium loss, and that leads to secondary hyperaldosteroninemia, and patients present with hypokalemia. Most of patients have hypomagnesemia because the loss of transepithelial voltage impacts in magnesium and increases magnesium reabsorption at the time. Hypohidrosis and hypolacrimia are present almost in every patient with Ehrlich syndrome. So good. Let's go to another topic. That is the tubular magnesium reabsorption. I think that you are aware that the free filtered magnesium is the main locus for magnesium reabsorption is the tongue. And we are talking, this is produced paracellularly, and now we are going to talk about the disease related to the impaired magnesium reabsorption at the time. So as I said, 65 to 75% of total magnesium reabsorption occurs at the tongue and occurs paracellularly through the action of Claudin-16 and Claudin-19. The driving force that allows calcium and magnesium reabsorption is the transepithelial voltage, and that is the result of the action of the sodium-potassium chloride channel and the secretion of potassium through the Ronke channel at the tubular side, and the sodium and chloride reabsorption through sodium potassium ATPase and chloride channels on the basolateral membrane. So Claudin-16 and Claudin-19 forms a complex that increase the paracellular permeability to calcium and magnesium and this is because there is an uncoupled reabsorption from sodium and chloride, and that increases the transepithelial difference and is the driving force for magnesium reabsorption. Familiar hypomagnesemia with hypercalciuria and nephrocalcinosis is a rare autosomal recessive tubulopathy with an incidence less than 1 per million of population, and was described by Michaelis Castrillo several decades ago. It is characterized by severe urinary magnesium wasting associated with hypercalciuria and progression to CKD. And the initial patients, the initial description, patients presented with polyuria and polydipsia, urinary tract infection, hyperuricemia, hypomagnesemia. And we have said already severe magnesium and calcium wasting by urine, bilateral nephrocalcinosis, kidney stones, low citrate in urine, some of them presented with incomplete distal artery, hyperparathyroidism, and CKD. High fractional urinary excretion of magnesium is found, but some patients may have magnesium serum levels within normal limits, and that is observed when patients have advanced CKD. And you can see here the nephrocalcinosis is a severe and bilateral nephrocalcinosis, and is a hallmark of the disease, and it appears in every patient. And later on, in some patients with this tubulopathy were seen to also to have an extrarenal phenotype with ocular involvement. Patients presented with reduced visual ability, macular coloboma, retinopathy, nystagmus, and severe myopia. In 1999, Dr. Simon and Coles described and discovered the paracellin 1 that later on was named Claudin-16 as that patients with this tubulopathy have loss of function mutations of Claudin-16. Some years later, in patients who had a similar renal phenotype, but also an ocular phenotype, were also studied, and Dr. Conrad described a second gene causing the disease, and this gene is Claudin-19. And therefore, it was established that patients with familial hypomagnesemia, hypercalciuria, and nephrocalcinosis, that these patients had Claudin-16 or Claudin-19 mutations. Claudin-19 mutations were discovered mostly in patients from Spain, and in Spain there is a founder mutation of Claudin-19, but also Claudin-19, there is a geographic distribution. So the south of Europe, the Mediterranean area, there are more patients with familial hypomagnesemia and nephrocalcinosis. Most of the times are related to Claudin-19 mutations, whereas in Central Europe or other geographical areas of Northern Europe, Claudin-16 is the prevalent gene, the underlying gene defect in these patients. In Spain, we have had the opportunity to see many patients with this disease, and the clinical manifestations are quite similar as the classical descriptions. So patients present with tubular phenotype with polyuria polydipsia, feeding difficulties, vomits, some of them with failure to drive, enuresis. Also, some patients may present with bone disease, rickets, and some neurological symptoms related to hypomagnesemia like cramps, even seizures. Laboratory findings, hypomagnesemia is a hallmark of the disease, but patients with advanced CKD may exhibit normal magnesium. But severe hypercalciuria and severe hypermagnesiuria are always present in these patients. Many patients at the time of diagnosis have CKD, and also intensive hyperparathyroidism, even to severe based on patient GFR is very characteristic. Patients may also present with a picture of partial distal RTA or incomplete distal RTA, and medullary nephrocalcinosis is also always constant. Extrarenal manifestations may be or not present, and patients with Claudin-19 mutations, not all of them, but most of them present with myopia magna, very characteristically with macular coloboma and other ocular manifestations. However, nystagmus is frequent as well and is related to hypomagnesemia, and it can be seen both in patients with Claudin-16 or Claudin-19 mutations. This table describes the regular values of urinary magnesium and urinary calcium that are seen in these patients. As you can see, the amount of calcium in the urine, the hypercalciuria is severe, as well as magnesium, and patients always have an increased fractional excretion of magnesium in comparison with serum magnesium. These are data from the French series, and what is also for me very important is that patients hypercalciuria as well it is described to be very severe. With treatment, patients present partial response, and we are able to reduce the amount of calcium in urine. But over time, and probably in parallel with progression to CKD, the amount of calcium in urine goes down. And this characteristic may be not so remarkable, and this is important because sometimes patients are diagnosed later on the disease, and maybe you can observe that patients may not have such a severe hypercalciuria that at the beginning of the disease. Some patients may have different phenotypes. For instance, this is a patient with a late diagnosis, and you can see that the patient had a picture of rickets. And so sometimes be aware that this tubulopathy may present with not so prototypic phenotype, and which, if you have a patient with severe bone disease, always look for this tubulopathy and think about that. If you see severe hypercalciuria, always check about magnesium in urine and think about the tubular, about this particular disease. Also, in the retinal imaging, if you see the macular coloboma is very prototypic of the disease, and there are some patients who have been diagnosed by ophthalmologists and not by nephrologists. So whenever you see, it's important to educate ophthalmologists that if they see patients with this phenotype, ocular problems, to send those patients for further evaluation. So the phenotype of the disease is quite constant, but over time, and these are very recent data that we have, and nowadays patients probably are diagnosed earlier, and we can see here that despite nephrocalcinosis is very frequent, some of these manifestations are not so severe at the time of diagnosis, which is really good. And this is our last study on including 30 patients from 22 families, and you can see that in Spain, most of the patients present with Claudin-related mutations, and this particular mutation is a founder mutation, and that we have the opportunity to study patients with variability in phenotype and in disease progression and severity, but with the same genotype. And this is the topic of our research, and that is what we are very interested in the disease. So what about the ocular phenotype in Claudin-19 patients is less well known, but in our patients we saw that 60% of them, they have a myopia magna, macular coloboma, and nystagmus as well, but 20% of them may present with mild myopia or astigmatism, so not every patient has severe ocular presentations, and even 20% of patients we were not able to see any ocular manifestation. Also, it is important to note that there is no correlation between ocular impairment and progression to kidney failure. Let's go to the questions. I will read these questions. So, what of the following manifestations is not required for the diagnosis of familial hypomagnesemia with familial hypomagnesemia, hypercalciuria, nephrocalcinosis? So, option 1 is hypercalciuria, option 2 macular coloboma, option 3 increased fractional excretion of magnesium, option 4 nephrocalcinosis, and option 5 all are required.
Yeah, please vote. We'll have about 30 seconds to think and to vote. Good, Gema. I will read the answers for you. 4% say hypercalciuria, 60% maculocoloboma, 5% increased fractional magnesium excretion, and 30% all are required. And nobody said nephrocalcinosis.
Okay. So I think most of you are very right, and macular coloboma is limited to some patients with Claudin-19 mutations, but patients with Claudin-16 mutations do not present severe ocular anomalies, and they don't present macular coloboma, being the renal phenotype similar for those both tubular diseases. So let's go about outcome and progression of the disease. Both Claudin-16 and Claudin-19, they exhibit a similar renal phenotype, but it has been described, and these are data from the French series, that patients with Claudin-19 mutations may progress faster to renal failure. And these are patients with the survival free from CKD stage 3, and you can see in the black line these are Claudin-19 patients, and in the discontinued line Claudin-16 patients. But in France, like in Spain, most of the patients are Claudin-19. So we still don't know if that is true or not. And Professor Conrad is leading one of the projects at the ERKNet, and is leading a larger study trying to collect data from several patients to answer this question. We cannot, in Spain, we cannot compare because we almost have no patients with Claudin-16 mutations, but we can see that in the contemporary cohort, we have patients with the median and age of diagnosis nearly at 4 years of age, but it's very variable. But we can see that there is, despite the same mutation and despite most of the patients exhibit even the same mutation, the progression is very different. And there are patients who progress very fast to CKD, to end-stage kidney disease, and nearly 17% of patients at 4 years of age were on dialysis or had required a renal transplantation, while others may progress less with a longer time. And even now, the median renal survival in the whole cohort is 25 years. But you can see that there are patients that is one of focus of our area of interest, who progress very fast, very severely to CKD, to end-stage kidney disease. We have seen, and this has been described in the literature, that more severe phenotype is seen in females. And indeed, in our study, 80% of females progressed to end-stage kidney disease versus only 40% of females were in the subgroup of patients not requiring renal replacement therapy on the long term. And in our cohort, also 73% of patients present with ocular involvement. So not every patient present with ocular manifestations, at least severe ocular manifestations. And these are also recent studies. And this is the comparison between our founder mutation of Claudin-19 versus other mutations, and we did not see any correlation between phenotype and genotype, and there is no, at least in Claudin, in our experience, Claudin-19 mutations don't impact on the rate of progression. But we have seen that, as I said, that females may progress faster, and despite not being significant, because the numbers are very few, girls seems to progress faster than males, and also they have a worse outcome. So what are the factors associated with faster CKD progression in familial hypomagnesemia, hypercalciuria, and nephrocalcinosis? It has been described, and I said that Claudin-19 mutations may be of worse prognosis than Claudin-16, but still we need to have more knowledge about this. Female gender, and also higher PTH levels at diagnosis and higher urinary excretion of magnesium and calcium had been related to more severe phenotype and to faster progression to CKD. And probably there are other factors that are still unknown. And this is one of my last slides, but I would like to say that there is a variability of the disease severity even in siblings with the same Claudin-19 mutations. In other diseases, in other genetic diseases, the second sibling of the family may present a better outcome and may benefit for early diagnosis. But in this particular disease, we haven't seen that, because there are examples for several different families with two siblings affected. And for instance, you can see this is in this family one, and the older kid was diagnosed at 9 years of age. It was diagnosed because of the ocular phenotype, had mild CKD, and at 18 years of age still is on conservative treatment, whereas the girl who was diagnosed at the first 3 months of age was diagnosed by family screening, and before 2 years of age required a renal transplantation. And the older child has a severe ocular phenotype, but the youngest child has no ocular phenotype. And we have seen similar experiences in different families. So it looks like even with the same genotype, there are other unknown factors that may explain the different phenotype, and what is more important, the different rate of progression to CKD that by now are unknown. So treatment of familial hypomagnesemia, hypercalciuria, and nephrocalcinosis is supportive. There is not cure, and patients are treated with oral supplements of magnesium to avoid the symptoms. Many patients still persist with low magnesium, and many times you are not able to correct and to normalize serum magnesium, and the target of the treatment is just to avoid the symptomatology. We use low or medium dose of thiazides to reduce hypercalciuria. Not every patient has a positive answer, but we believe that reducing hypercalciuria is a good outcome, and we should try. But also it's important to be cautious and not to cause dehydration, because patients have polyuria, and also we use citrate to protect for hypercalciuria and avoid acquired renal damage. And the kidney transplant is the final treatment, and it cures the disease. And there are few examples, but carriers can be donors, and patients have a good outcome after being transplanted. So we have talked today about diseases caused by Claudines and by impaired paracellular transport, paracellular tubular transport, but there are other diseases causing renal hypomagnesemia, and this is a very nice algorithm, and I put them here. There are different diseases, but whenever you see hypomagnesemia or renal origin, you should go through this algorithm trying to make the differential diagnosis. And with that, I thank you, all of you, for your attention, and I will be happy to answer if you have any question. Thank you.
Thank you very much, Gema, for your very comprehensive presentation. Very nice overview of this rare disease, but which can be really very severe. So I think it's very important that it's recognized and that the diagnosis is made. So we have some questions. I will start with the first one. So one question is, why do patients with FAH and C develop, or at least some of them develop early kidney failure, while distal RTE patients with similar degree of nephrocalcinosis don't progress this fast?
Yes, this is an open question. It has been hypothesized that maybe there is a tubular developmental defect underlying the disease, and we are very interested in looking for other modifier genes, and also part of our research we are focused on the link between the gene mutations and renal fibrosis. And still we as a group, there are other groups studying the same area, but this is one. These patients, all of them progress to CKD, and that is why it's not only the progression is not related to hypercalciuria, or there should be there should be other factors, and the major hypothesis is that there is an underlying primary tubular developmental defect in this disease.
Okay, and do you have some data from the kidney biopsies from those patients?
Patients are not biopsied, and then there are very few data, I think. What I have had the opportunity to see some patients, but the histology is non-specific, and what happens is that we don't have a good information about that, because the diagnosis doesn't require renal biopsy.
Yeah, sure. I'm just curious. that
Yeah.
maybe we can learn something from that, from occasional biopsies. So there is another question regarding PTH levels in those patients. Can you comment on that?
Yes, thank you for the question, because I missed to talk about this. What is remarkable for the disease that even at diagnosis, patients present very high PTH that is out of is unexpected for the GFR of the patient. And one hypothesis is that these patients have normal calcium in serum calcium, and it has been hypothesized that high PTH is required to keep a normal level of calcium in patients with severe hypomagnesemia. What we have seen, and it has been described by other authors, is that those patients with higher PTH at diagnosis is a marker of faster progression. So it's a risk factor if you see high PTH. Also, what happens is that magnesium may be not regularly checked at diagnosis. So if you see a patient with nephrocalcinosis, hypercalciuria, severe, and a large amount of magnesium in urine and high PTH, think about the disease.
Okay, so it can be also a useful tip for the diagnosis.
Yes.
Right. Okay. So there is one question about the ocular symptoms, whether they change or improve, or I don't think so, post-transplant. So about the evolution of the ocular presentation.
No, thank you again. Of course, I mean, transplantation we don't have treatment for the ocular manifestations, and many patients have an important visual disability. The macular coloboma regularly is bilateral, and it provides reduced visual capacity, and patients may have myopia, they may have more than 15 dioptries, so the defect is very severe, and we don't have treatment for that. And of course, renal transplantation has not played a role on ocular treatment.
Yeah, right. So there are some questions about the treatment. One question is how much magnesium do these patients need to routinely? What is your experience?
So the experience, I think we try to reach a level of 1.2 milligrams per deciliter of magnesium, or try just to avoid symptoms. I put patient, you need to divide magnesium supplements 3 times per day at least, and just to increase GI tolerance. And regularly, I don't put more than 50 milligrams per kilo per day, because even if you increase the dose, the results will not be very different, and you will increase the GI problems. So the supplementation is important just to avoid symptoms, and what we do is we prescribe a moderate dose, and it's important. For instance, I always teach my patients to have a dose before doing exercise or sports, because that increases their tolerance. And sometimes when they are very tired, kids are very tired after a whole day of activities, sometimes they take an extra dose, but that is regularly after some sports. But the idea that we don't know exactly what dose, but the we supplement magnesium till the point that the patient has no symptoms, no cramps, not muscle spasms, and that is the goal. So, and also we start and we increase the dose progressively. We may start about 50 milligrams per kilo per day and then go up based on symptoms and based on patient tolerance.
Mm-hmm. You mean 50 milligram of elementary magnesium?
Yes, sorry, yes.
Okay. And do you have a preference for a certain magnesium salt?
Well, we don't have preference because there are so few salts available, at least in our country, that what we use is what is on the market. But it's a big problem because it's a big problem because there is not a big choice of magnesium. For instance, there is not magnesium citrate that could be a good. I mean, if you have magnesium citrate, it could be a good option. But for instance, it's not available in our country, so we use so what I mean is that at least in Spain, there are several supplements there is not a unique presentation, and sometimes is what you have. Also, in our countries, these patients, I mean, supplements are not being reimbursed, and also that is a big problem for these patients because it's a very long-term treatment.
Yeah, I think it's a problem in a lot of countries.
Yes.
These magnesium salts are not reimbursed, and we don't have what we would like.
Yes, I will avoid magnesium chloride, for instance, because these patients have a tendency to acidosis. So I citrate magnesium or check what you have in your country.
Right. So there are some other questions about hypomagnesemia. I think people have experience with that. So the seizures in those patients, are they secondary to hypomagnesemia, or it might be a primary neurological problem?
I don't think these patients have neurological problems. I think they have when they have other factors like fever, so they are prone to seizures because they have low magnesium. But I don't think they have neurological problems.
Okay, there is another interesting question. Have you considered transdermal magnesium supplementation?
Okay, I haven't think about that, but maybe it's a good idea. Yes, I don't know. I will check that if that is available.
Right. So I was just wondering, while you have told that you are using thiazides to reduce hypercalciuria, but don't you see a worsening of hypomagnesemia then in those patients?
Well, that's the question. I haven't told that in these patients potassium, and I think this is very important for the differential diagnosis with distal RTA. Potassium is in the higher normal level. So because those patients have CKD, you don't mind of using low dose thiazide, so you keep potassium within the normal range. And of course, in a patient with my experience is that patients may have very low magnesium, but they tolerate it very well. So, but in a particular individual patient with very severe hypomagnesemia, I will check if removing thiazides will be of benefit or not. I will consider that, but because we use low thiazide dose, I don't think this is a major problem. But of course, you can consider it.
Okay, so there is another interesting question from Marie Barbara. Have you looked at some lifestyle factors that can be associated with disease progression? Is maybe something here? Some lifestyle factors, I don't know whether drinking more, less, or some other lifestyle, or having healthy lifestyle, or which can be associated with the disease progression. Because it's so different. There are people who are doing quite well with the same mutation, others who are doing very poorly.
Yes, this is remarkable, and sometimes you, I mean, we, of course, if you have a risky lifestyle, it's not good for kidney disease. And for instance, it's very important to avoid the hydration episodes for gastroenteritis in infants with this disease, and as any patient with severe bilateral nephrocalcinosis. But the other side of looking at that is that we have some patients who have been diagnosed on the 20s with a milder phenotype, and the reason that the diagnosis was made late is because the phenotype was milder since the beginning, where other children, infants, you see a very severe phenotype, very severe and faster progression with reaching end-stage kidney disease before 2 years of age, and they may have siblings from the same family doing fine. So, of course, I think that there are other factors that we need to discover to be able to. I mean, it's very important to know more about the pathogenesis of the disease, not only related to the magnesium transport, to discover potential drugs to treat this disease, because nowadays we are treating it we are only providing supported treatment.
Right. Yeah, it's very interesting. You have also mentioned that females are more severely affected, at least in your cohort. So, do you have any thoughts on the mechanism?
What? Sorry?
Do you have an idea why females have a higher chance to develop end-stage kidney disease?
In the past, it was invocated that frequent urinary tract infections could be a reason, but we don't see many infections in our patients. And so one of the factors we are studying if there is any hormonal sex impact on tubular function. We are studying that, but we don't know. But in the past, urinary tract infections were proposed as a possible explanation, but we don't see many of them. So we believe that maybe it's something on the tubular impairment, maybe driven by sex hormones or sex-induced factors. That is one of the areas of research.
Yeah, very, very interesting. I don't know whether there are adult nephrologists who are listening, but I was wondering, do you have some information about pregnancies in those patients? Do you have some of those who got pregnant and had children? How they are doing then?
As far as I know, and there are no major differences from other women with CKD, as far as I know. Okay. But even, for instance, we have a family, and I mean, we have a family, and the lady on dialysis was being studied for kidney transplantation, and they checked their family, and that lady had an unknown disease, and because the family showed it was a consanguineous family, and there are other members with familial hypomanasemia and nephrocalcinosis, and that particular woman had several kids. So as far as I know, there are no differences.
Okay. Very nice, Gema. I think it's 5 o'clock now, so I would like to thank you very much for this very interesting presentation. I hope that all people who listen to this webinar or who will watch it on the website of ERKNet, it's very important because the webinar is recorded, so it still can be seen at the ERKNet website, would recognize this disease, diagnose it, and I hope that some treatments will come in the future, so those patients can have better treatments than only symptomatic treatments. Also, thank you, the audience, for your attention, for being so active, and please follow our webinars on the website and on our mailing list. Thank you very much, Gema. We will close the webinar.
Thank you. Thank you very much. Bye.
Bye.